Everyone, welcome to this ASCO GU virtual roundtable. My name is Brian Rini, and I'm a professor of medicine at Vanderbilt and Vanderbilt Ingram Cancer Center. And I appreciate being joined today by several experts in the field, and I'm going to have them introduce themselves, and we will start with Dr. Plimack.
Hi, I'm Betsy Plimack. I'm a GU medical oncologist at Fox Chase Cancer Center in Philadelphia.
And Dr. McDermott.
David McDermott. I'm a medical oncologist here in Boston at Beth Israel Deaconess Medical Center.
Thank you. And Dr. Voss.
Yeah, hi, Martin Voss. I'm a geomedical oncologist also, and I practice at Memorial Sloan Kettering Cancer Center in New York.
Great. I appreciate you all joining us, and you all have extensive expertise in kidney cancer and drug development, so it should be a fun discussion. We're going to touch on several areas in the landscape of kidney cancer, incorporating some of the data that was presented just recently at ASCO GU in San Francisco. And we'll start with frontline clear cell kidney cancer. We'll talk then about non-clear cell. We'll cover some of the other major updates, including the adjuvant setting, and then probably end with, sort of what you're most excited about, as we head into the future and to the main ASCO meeting. Martin, didn't mean to ignore you there. We'll give you the final word of what you think any ASCO data significantly impact your practice, and where do you stand on this debate?
Yeah, it's good, like Betsy said, it's good to see these analyses, and the data being put to use, remembering that, a lot of patients committed to these trials and a lot of work went on, on part of the study teams and continues to, right? We're still all logging data for these trials. So I think it is important that we keep looking at this data and making sure that it can sort of shape decision-making. I would say there were no surprises here. I think it is good that we've now seen, data north of 4 years for all the pivotal trials that we need to consider when we make decisions in the clinics. And I think the theme has been the same. We see that group of patients who clearly benefited from CTLA-4 PD-1 inhibition continue to benefit. I think the most impressive part of that was the duration of response data that was seen for those patients who are still being followed anyway, right? For those responders that are still being tracked, 50% of them are still in response north of 7 years follow-up. I think that is important. And I think that does help with decision and with discussions in clinic, because what I usually tell patients is I can't predict how they're going to do, but I can reference some examples, and I can tell them now that there are patients that we studied in similar scenarios on a clinical trial, and those who did have a response, which isn't everyone, had a very high chance of holding on to that response, not only for months, but for years. The other thing that I was very happy to see and have been pleased to see for the BMS data set is that we see toxicity data and how it evolves over time. We've seen that for ipi/nivo before, and it's one of my frustrations for all the TKI IO data sets. We see that tornado plot again and again, and it's not going to change because it won't change. And even if it did change to some nuances, to the highest grade tox per patient, doesn't really help think through what happens to patients over time. And that's what we really care about, right? We care about keeping patients on the same regimen for a long time, the good and the bad, the chronicity of toxicity and the duration of their response. And I think it would be very helpful if we could see, some prospective assessment of what happens with the TKI tox over time, what happens with IO tox once patients come off after 2 years of pembo, for instance. And maybe I'm just missing it, but I don't think, we're seeing the data, although that data is being collected and there's still lots of data entry happening on some of these trials.
Yeah, I agree with you. I think certainly we've all treated patients with TKIs for years, right? Individual patients, let alone collectively. And, as patients get years out, I tend to give less and less TKI, either stop it entirely or give very generous breaks, right? And so, but to your point, we don't have even tox data, let alone quality of life data, et cetera. We just have our sort of collective experience that, my experience anyway, by the time patients get years out, clearly they're tolerating it reasonably well, otherwise they wouldn't be there. And I'm so liberal with breaks, and I certainly have patients where I've stopped it. When patients get to that 2-year point of IO, I generally stop, and I also have a discussion about stopping the TKI, and it's hit or miss. Some patients say, "Yeah, great, doc, I'd love to," and other patients are tied not inappropriately to this drug that they think is keeping them alive, and they're not wrong, right? So I think that's a different discussion. But you're right, we don't we don't have granular reporting because, to Betsy's earlier point, we didn't really plan for success, I think, in these trials, right? And have faithful data collection and second therapies and long-term tox and all that stuff that now we're like clamoring for the data, but it doesn't exist as much as we would want. And Martin, just maybe to follow up with you, what is your approach, your sort of general approach then? Clear cell patient walks in, they see you in clinic.
So the first decision for any of us, I think, is between IO and IO-TKI, right? If they are in need of systemic therapy, some patients are not, but if they are in need of it, I do look at the pace of disease and I think, Betsy mentioned this before, and so the kinetics, my concerns of how quickly they are getting worse clinically, and can they afford, the room that we may need, right, with a higher upfront failure rate with an IO doublet that then might necessitate second-line therapy. And if a patient has intermediate porous disease, low volume, asymptomatic, I continue to be very encouraged by the long-term data for ipi/nivo, and I consider that certainly for any patient. And patients who have a higher pace of disease, and I'm concerned that they're getting worse quickly. I need something that has a low failure rate, and that we've seen now with the TKI-IO combinations, can rely upon that.
Yeah, and I think that's probably the one area that people do agree on, is that higher volume, higher pace. Now, we all might define that differently, right? I think you kind of know when you see it, but if you ask me to quantify it, I might struggle to say, well, it's this much disease or that much disease. Speaking of, we did see some data that I think Victor Grunwald presented from the CLEAR study, the Len-Pembro, about baseline tumor burden and association with outcome. And if I remember correctly, really the one thing that struck me was the chance of a CR went down with higher tumor burdens. Not surprisingly, I don't think he broke it down into primary in place or not, but I assume a lot of those patients would have primary in place. So does anything about that data set for any of you impact the way you think, or is it sort of, yeah, that's kind of what we thought?
I think it reaffirms things yet again. And I think, I would look at the other end of the spectrum, looking at these 4 subgroups. So he broke things down by separating all the patients into, quartiles by sum of target lesions. So he has an estimate of volume of disease. And we know there's all kinds of, issues with RECIST assessment. But I think what was helpful to see is that even in the group with the biggest burden of disease, the failure rate, the PD rate, remained low. So you may not have significant shrinkage. The CR rate goes down, which sort of makes sense from a common sense perspective. It's just harder to bring that down to 0. But that does not mean, that you can't control the disease. I think the overall ability to control disease, was quite good, under 10%, even in that largest volume, group of patients. And I think that's reassuring for that regimen.
Yeah, agreed. And some of this, of course, has to do with RECIST categories are based on percentage, right? Not absolute change, in the absence of new lesions. So I guess it would have been nice to see that. Might be harder to progress if you have high volume because it's 20% of a higher baseline, right? So you have to have, so it kind of works a lot of ways. But I agree. It's sort of interesting data, sort of, to me, sort of fits what we think. I'm not sure it impacts my practice too much.